Hi everyone, I want to make this presentation on asthma. Asthma is worldwide and many people have been affected. We all know that it is hereditary and also environmental factors play a lot of roles here. So it is both hereditary and environmental problem. What are the triggers? Pollen. Some children, even adults that are asthmatic, will become sick when they go to farm and they are exposed to pollen from plants. And that is why the attack is more severe around springtime when the plants are shooting up, flowers are blooming, and a lot of farming activities will be going on. Occupation can affect the rate at which you come down with attack, depending on where you work. Like if you are dealing with pollens, dust, animal dander, and so on and so forth, even chemicals that could trigger. I will still discuss more. Upper respiratory tract infections, common cold, sneezing, runny nose, most times in children will be the first thing that will occur before they come down with attack. GERD, gastroesophageal reflux disease. As a matter of fact, when you have been treating asthma for a while and you are doing your best and you are not getting good outcome, you need to rule out this in such patients. Dust. Yeah, that's why we always advise that asthmatic patients, particularly families that have children with asthma, should please clean the house and not use rugs or carpets that could retain dust. So ceramics would be better or wooden floor in these families. Exertion. Exertion will exacerbate asthmatic attack. As a matter of fact, we always advise children that are asthmatic and are doing sports to take their bronchodilator 10 minutes to 30 minutes before the sporting event. Cold weather, that is very common in temperate countries. The colder the weather, the more likelihood of coming down with attack. Animal dander, animal fall, changing leaders of animals on farm or even at home. Some react to cats and so on and so forth. Smoke and smoking. When I say smoke, it could be exhaust from anything or people cooking with wood. And smoking cigarette. The parents are smoking, the children are asthmatic. Wow. We're not going to get out of that on time, and it will appear as if the medications administered are not working. Aspirin or beta blockers. The patient is asthmatic and now has been placed on aspirin or beta blockers or even combined. It's likely it will appear as if the medications are not working. Feathers or fall. Some people, their pillows are made of feathers. And that might be the only reason why this asthma has not been under control in them. Perfumes, new paints. Not everyone will be able to cope with some strong perfumes, particularly asthmatic patients. And worse, the house that has just been newly painted, or you've just relocated to a new house, and the paints are still fresh, the child may not sleep that night, might come down with asthmatic attack. I'm not limiting this presentation to asthmatic attack in children. It's also in adults as well. Okay, here's the question. Doc, the treatment is not even working. Oh, then I need to ask you some questions. What povers are you using? Oh, I'll tell you, I'm using Ventolin or Proven. Okay. Are you using them appropriately? Yeah, the person will say, yes, I am. Can you demonstrate how you use it? Then you know. And if that demonstration is not proven to be the right way, please demonstrate to the patient. Using aero chamber with pover will make delivery to be more appropriate and reliable. Check the expiration of the pover. Sometimes it might have even expired, and then you are using it, you are not going to get results. Dosage and frequency of usage. Might be this is the time to adjust the dosage in this person, and probably you have to increase it. If the person is using it appropriately, correctly, and it's not expired, then either you change the medication or you increase the dosage. And of course, in this patient, we need to ask, do you know the triggers in you? Do you know the allergens? Have you been tested and the specific allergies in you have been found? Because it's possible some would have taken that and they would have been told this is what you're allergic to. Particularly in children, parents should watch what exactly their children will always react to. There was a case of a family. They have a son with asthmatic attack, and the son will always have attack whenever he went to the grandmother's room. And unfortunately for the grandmother, she was labeled as being demonic because the son will always come down with attack while in her room, not in any other room. So when the doctor heard about that and investigation was made as per what was in the grandmother's room that could have triggered the attack, lo and behold, the pillow was made of feathers. And the family rift was solved. The problem became abated, and the boy started enjoying his life better. You can teach the patient on how to improvise if they don't have money to buy aero chamber or is lost. Plastic water bottle could be used for this purpose, and I'll make a video later on demonstrating this. So you can just use the plastic water bottle, cut it in half, and tape the rims with bandage, and I'll make that demonstration later on. So it's not all the time that you have to spend your money to buy aero chamber, that you have money to buy that, that's great. and sometimes it could be lost, but if you have this improvised device, you can use it anywhere. That's what you call asthma action plan. Green. Green means you only need maintenance. How do you group people to green? They use puffs less than 3 times in a week, and they don't have any night trouble. Yellow. There's laws of adequate control, and characteristics here is that they use puff more than 3 times in a week, and the night symptoms is greater than 1 per week. They can't function well. So the next plan here is they have to visit their doctor, use their puffer as required, and before any exertion. What if the patient is in red category? How do we put them here? They are in acute asthmatic attack right now. The symptoms are continuous. And what are the symptoms? Cough, chest tightness, sweating, feeling of dying, shortness of breath, wheezing, and it could be silent chest, can't speak anymore, restless, or even agitated. The reason why I have not brought out signs and symptoms of asthma separately is that they are all incorporated here. Now, as the asthma action plan category red, the signs and symptoms are incorporated here. And let me repeat. Asthmatic patient will be coughing, will complain of chest tightness, will be sweating, having fear of dying. They will be having shortness of breath, wheezing that you could even hear without stethoscope. But sometimes the chest is silent. When the chest is silent, it's not an indication that the patient is doing well. As a matter of fact, that is a bad sign that the patient is about to die. So they won't be able to speak at that level. All they could show is restlessness and agitation. Please call 911. But while waiting for 911, I trust those good people, they rush down to your place, pick you up, that before they come, grab your Ventolin. Every 20 minutes, administer it. I believe before you do that 3 times, they would have arrived. How can you distinguish COPD from asthma? Do spirometry. If FEV1, forced expiratory volume 1, rises by 10 to 12% after administration of bronchodilator like salbutamol, then it is asthmatic. Why? It is reversible. But COPD is irreversible. So you won't expect this rise because it won't come. Bronchoprovocation test with methacholine or histamine is done in some centers, but I'm more comfortable with spirometry to make that distinguished classification. Eosinophil is not specific to asthma, but it is useful in monitoring medication effectiveness. For example, if your patient is on corticosteroids, when you assay your eosinophil, periodically, it will give you a clue whether you are winning or not. Okay, the treatment generally is centered around education on the chronicity and reversibility of this disease. It is reversible, should not be killing. And many times to many of these drug manufacturing companies, many medications are available. We'll go over them in the course of this presentation. Let these patients know that they need to avoid known allergies. If they don't know, we don't blame them. But please take the pain to identify the allergies on your own. Then smoking is not a good option around them. So either they themselves or they are partial smokers. I mean, somebody around them is smoking. That is not good. Environment should be kept clean. Preferably wooden floor, ceramic floor, not rugs, not carpet. Sorry, I'm not trying to spoil market for the rug and carpet companies, but if my patient should have asthmatic attack, I would like them to live in a room or in anywhere where they could do the cleaning and take the dust off as quickly as possible. Cover, Ventolin, that is salbutamol. That alone is okay if the level of attack is mild. But if the level of attack is a bit high at the level of moderate level, then add Flovent to the Ventolin. If that is not enough, if you are not winning, then add what we call long-acting beta agonists, salmeterol. Inhale corticosteroid like Flovent and montelukast. I'll tell you more about that later on. And if you are still not winning and this patient keeps coming and is now having acute attack, then ipratropium and salbutamol with budesonide neb. As a matter of fact, I would advise that my patients should buy nebulized machine at home and have this medication around, not expired one. It can be recalcitrant. You've done all this, yet you are not winning. Well, you can give salmeterol, that's long-acting beta agonist. You can give oral prednisolone. You can give montelukast, omalizumab with the specialist advice, magnesium sulfate, and if you are still not winning, general anesthesia. Later, I'll still go over this in subsequent slides. Ipratropium is better in beta blocker induced bronchospasm. It has a longer bronchodilatory effect. Though the onset is not quick, but it lowers the tachycardia and tremor associated with salbutamol. Tiotropium is a longer acting form of the anticholinergic. I mean, longer acting form, longer than ipratropium, but they are in the same class. So that one is used once daily. It's not meant for acute phase, but for maintenance only. Theophylline, be careful because there is very serious side effects. Aminophylline is given IV, whiteophylline is given per oral. Be careful also because of the possible side effects. Salbutamol and terbutaline will be the first choice in acute phase and in any asthmatic patient trying to participate in sporting events and will need to take a POVA before the event. Salbutamol or terbutaline will be the first choice. Isoproterenol and epinephrine are good, but not commonly used because of the side effect on cardiovascular system. Beclomethasone, budesonide, mometasone, fluticasone, and cyclosonine, they are used regularly on daily basis. Please, not PRN. You must rinse your mouth after. Doctor, why? Yeah, to prevent pharyngeal candida infection. You may be told to quadruple your dose if there's history of severe exacerbation in the past. For example, if you have been placed on 250 microgram beclomethasone, the doctor can shoot it up to 1,000 microgram. What I'm trying to explain here is that all these povers that inhale corticosteroids are used on daily basis, okay? While salbutamol or terbutaline could be used as PRN meds. The long-acting form of beta agonist, formoterol, salmeterol, we use only in those on inhaled corticosteroid already, or when they are combined. They work to prevent nocturnal symptoms. Savoliquas or montelukast are together called leukotriene receptor antagonists. They have anti-inflammatory effects, but the anti-inflammatory effect is not as strong as those of inhaled corticosteroids. You can add either of these, savoliquas or montelukast, to inhale corticosteroids to prevent exacerbation. But we don't prescribe savoliquas or montelukast in acute phase. It's for prevention. But when you add them to inhaled corticosteroids, then you are going to get better results. Their work is to antagonize leukotriene receptors. Sometimes when you have used your inhaled corticosteroids, the dosage has been increased, a new one has even been prescribed, you've done everything, yet the situation seems not to be abating. Then you discuss with a specialist. Immunoglobulin E neutralizing antibody could be prescribed. Omalizumab is an example here because IgE will reflect how sensitive you are to the allergy. So when the situation is getting out of hands, the inhaled corticosteroids is not helping, then you need to find something that will neutralize the rate at which you express sensitivity to the allergen in form of immunoglobulin E. And a specialist can prescribe omalizumab for that purpose. If you are using Trovlin, I know Trovlin is given per oral, please do therapeutic level because of the side effect. Yes, my sister is asthmatic, but she's pregnant. What do? We are not going to leave her to die with pregnancy. It's not even a situation where it should kill. So she could continue her Ventolin and Pulmicort. Ventolin is the trade name for salbutamol and Pulmicort for budesonide. And I need to state here categorically, it's not that I'm advertising for any company. I've never been influenced by any company. So just telling you what I know. Asthma can cause preterm labor, can also cause congenital anomalies, low growth, preeclampsia, and placenta previa. In an emergency situation, severe acute asthmatic attack is ongoing. Okay, what do? Admit, give salbutamol, 2.5 milligram, ipratropium, and budesonide. all these three in your nebulized machine. You can give your IV fluid for maintenance purpose, oxygen if the O2 sat is less than 94%, as 4 liters per minute per nasal cannula. Is there any ongoing concomitant upper respiratory tract infection here? Treat. Intravenous hydrocortisone should be administered. Then follow it up with oral corticosteroid in form of prednisone, 60 mg per oral once daily for about 7 days and tail off. Tail off. We don't stop corticosteroids suddenly. If not, we have Addisonian crisis. If you are not winning, magnesium sulfate could be administered. If you are not winning, general anesthesia. If this patient is having fever, then let's do chest x-ray. We might be dealing with pneumonia here. And of course, don't do this alone. Contact the pulmonologist, the specialist. There are so many medications that we could lay our hands upon, thanks to many of these companies for working on this, the reason why many people are no longer dying of asthma. Okay, CONDITION.WITH. Two medications are here, ipratropium and salbutamol. You name them. Advair, fluticasone and salmeterol, different dosages, depending on what you want. If it's discussed, there's higher dosage of fluticasone, and of course salmeterol is also higher, like 50 microgram, and fluticasone 125 microgram. The name of the Advair discuss is the concentration of the fluticasone component of it. Like discuss 125 means fluticasone 125 microgram. Discuss 250 means fluticasone 250 microgram, while the concentration of salmeterol will remain the same. Like discuss 500 means fluticasone 500 microgram. And Symbicort, that is a combined medication of budesonide that was named Pulmicort before and formoterol. So it depends on whether you are using budesonide as buffer with HFA, or you are using it in combination with formoterol, and the name will change to Symbicort. So it's still budesonide, but something else has been added to make it Symbicort now, which is formoterol, the long-acting beta agonist. Zenhale, that is mometasone and formoterol, is also available at different dosages of that mometasone, and formoterol concentration is constant at 5 microgram. So for the sake of my listeners and people watching me, I've decided to take the pain to go over some few medications that asthmatic patients may be taking, their trade name and the generic components. Pulmicort is containing budesonide, or budesonide is named Pulmicort by the company. Flovent is fluticasone, Quiver is beclometasone, Avasco is ciclesonide, and Asmanes is mometasone. Those are inhaled corticosteroids that you can lay your hands upon. Accolade, that is Savelucas, and singular is Montelukast. Ventolin is Albuterol, and Bricani is terbutaline. And Furade is formoterol, and Spiriva is tiotropium, Atroven is ipratropium, and Cervent is salmeterol. You can take a picture of this and go through them on your own later on. You can Google them and see the examples. So You know the name of those povers you are using. And some of them are even per oral. DROVENT. DROVENT is ipratropium and phenyltyrol combined. It comes in 4 mils containing 500 microgram ipratropium and 1.25 milligram phenyltyrol. You nab every 6 hours. If patient must take aspirin or is on exertion and the patient is asthmatic, then montelukast or staphylococcus will be very helpful. Let me repeat. If the patient must take aspirin or the patient must continue exertion and it is a must and this is an asthmatic patient, then montelukast and staphylococcus will be very helpful in prevention, not in acute phase. Symbicort, which is budesonide combined with formoterol, is good for both acute and preventive therapy. Okay, like some are for prevention only, while some are for acute phase, and some could be used both in acute phase and for prevention. Symbicort could be used for both, Ventolin could be used for both, and staphylococcus and montelukast is only for prevention, while all inhaled corticosteroid must be taken on daily basis. Yeah, it's my daughter and is having asthmatic attack. How are we expected to go around this? Okay, admit, do arterial blood gases, do that in everybody. If O2 stat is less than 94%, give the oxygen, but if it's greater, no problem. Nebulize ipratropium, pulmicort, salbutamol combined every 4 to 6 hours. Hydrocortisone could be given. The reason why I brought it out here is not that all these medications are different from what we use in adult, but something is different. We begin to weigh them. Now, 6 milligram per kilogram every 6 hours is a child. Now, that's hydrocortisone level that I'm going to give now. Then prednisone is 1 milligram per kilogram per hour for 5 to 7 days while tailing it off. Talking to a specialist about possible omalizumab to neutralize IgE. And of course, though it is not good for the heart, salbutamol intravenously could be used, but that is when all these have failed and you have discussed with your specialist. Magnesium sulfate could be administered if you've tried all the above measures. Now 75 milligram per kilogram, please slowly administer. Of course, then you're going to call those good people in anesthesiology department. You can give amoxicillin before considering general anesthesia, but we need to keep an eye on the vital signs. No success despite everything you've done. You've given everything, yet the guy is still in trouble. Like at the beginning, I told you, if the patient comes back and says this asthma is not going, you've checked the puffer, the name of the puffers, the way he or she administers it, the expiration, and you've called the specialist, they've given omalizumab, they've done everything, and you're not winning. Something may be wrong. Maybe we are dealing with a different diagnosis entirely. Have we ruled cystic fibrosis out in this patient? Because all we've done, we even have patient with cystic fibrosis, but it's not going to cure. Then vocal cord dysfunction. But if it is vocal cord dysfunction, there'll be no night wheezing. There'll be no symptoms at rest. How about GERD, gastroesophageal reflux disease? Because there's a different way to treat that, because we are going to even have a different presentation on gastroesophageal reflux disease. I promise, very soon. So let me leave it to that time, because you don't even need inhaler here. You need lifestyle modification, the way to eat, and some medications to neutralize the already produced acids. Raise the head of your bed and so on and so forth. Losing weight and many things like that. Posterior nasal drip. The person sleeps at night, particularly cold weather, and then everything is, just the secretion is just going there and causing trouble. Like I've mentioned, cystic fibrosis, cardiogenic syndrome. There'll be repeated otitis media in them, sinusitis and rhinitis, and sinusitis on its own could also present like this. So if you have done everything and the patient is not getting out of the trouble, please review and check, is this the right diagnosis? In conclusion, asthma is a condition affecting many. It should not be killing people because it is reversible. If properly applied, there are many medications to help with avoidance of triggers. In other words, there are many medications manufactured around the globe that could help to reverse asthmatic attack. But you need to know the triggers and avoid them. And it is not only that you will be prescribed good medications, you should be able to know how to apply them as well. Please contact your physician. This presentation is not replacing the responsibility of your physician and your own responsibility to contact him or her. Wishing all affected people well. And I pray asthma will no longer be killing people like it's doing now. Thanks to all these medications, and I wish all affected people will comply with their doctors and prescription. Thank you for listening.